Hi, everybody. This is Dr. Britt Talley Daniel, MD, neurologist and a headache doctor, doing another podcast in the migraine area. This time I'll be talking about cluster headache. And following my usual forecast in the previous articles, I'm going to have a clinical experience with a doctor, sees a patient, they talk and have a dialogue, sort of a teaching patient instructional dialogue. So the patient comes in the doctor's office, sits down, and says, "I get these sinus headaches, doc," the man said with a winsome smile, offering immediately a diagnosis. "Tell me about them," the doctor replied. "Well, I've had them for years, at least 10 years, I think, and they just come and drive me crazy," the patient grimaced. "They keep me up at night." "Oh, well, what can you do for me?" "I need to hear more about them," the doctor replied. "Start with describing their frequency." "They come for 8 weeks, and they just bomb me out then. Bam, bam, bam." The doctor watched him pound his fist into his other open hand. "I may have 4, sometimes 5 or 6 headaches a day, and the darn things come about an hour after I go to sleep. Just wake me up. Pow! I'm out of bed, running around my apartment. No position helps. Up, down, sitting, nothing gives relief. I take signing tabs till I own the whole company. I put ice on my temple, where it really hurts, right here." And he pointed to his temple next to his eye with his index finger. "Well, how long do they last?" the doctor wondered. The man looked at him with amazement, arching his eyebrows into furrows. 20 minutes, 30 minutes, then they stop. "How long does it take for the pain to come on, the doctor asked. "Ha! Not long," the patient said. "I'm just lying there, whoosh, the pain comes. It's nothing to hellfire in 2 or 3 minutes max. You wouldn't believe it. It comes on so fast I don't even have time to get ready." The doctor nodded and wrote some notes. "Do the headaches come at the same time every day, like a clock?" the doctor asked. "Huh, funny you asked that," the patient said, looking sharply at the doctor. "Have you heard of this before?" "Maybe," the doctor chuckled. "Keep going." "At night, do they come at the same time?" The patient thought a minute. "Yeah, like I'm out of bed at 1:10 every night, and I don't want to be. I want to be sleeping." "What time do you usually go to sleep?" the doctor asked. "Oh, about midnight," the patient replied. My wife drives the school bus, see, so she gets up at 5 and has to go to sleep around 10 p.m. I don't get usually till 9, usually." "After the headache goes away, can you go back to sleep?" the doctor asked. "Sure, like a baby, doc, but that headache may get me again that same night. And lately it's been popping up around 11 o'clock in the morning also." "So you get a headache an hour after you go to sleep every night, another one at 11 o'clock in the morning, a.m., right?" the doctor asked. "You got it, doc," the patient said, "but I may get 3 or 4 headaches the same day, scattered all higgledy-piggledy all throughout the day." "I see. Now, describe what these headaches feel like and tell me where they hurt." "Well, the hurt part is easy, right here, an inch inside my skull," the patient said, touching his temple again. "And they feel hot, like a needle, searing. It's incredible pain, doc. You don't want to feel it, let me tell you." "So on a pain scale of 1 to 10, these would be a 10, right?" the doctor asked. "No, doc, that scale doesn't fit for these headaches. These headaches are in a category of their own. They're beyond numbers." "Do you get any other symptoms besides the pain at that time?" the doctor asked. "Well, my wife says my face changes, like my eye falls down or something, my right eye. And I know my nose starts to run. That's the sinus part, doc," the patient said. "When your nose runs, is it clear fluid or yellow or colored?" the doctor asked. "Clear," the patient responded. "Anything else you can think of?" the doctor asked, like, does your eye tear or the white part of your eye turn red? "Yeah, my eye tears, but I don't know about the red part." "Do you get nauseated since it's a light or sound at this time?" "Not really," the patient said. "Does anybody in your family have migraine, like your mother or your sister?" the doctor asked. "Oh, yeah, my mom has migraine big time, but it was worse when we were younger. She used to tell us kids to watch TV and be quiet, and then she'd go to her bedroom and shut the door and not come out until supper," the patient said. The doctor nodded and put down his notebook. All right, so next I'm going to discuss what the International Classification of Headache, third division, says about cluster headache. And so they say that there were previously used terms, and those were ciliary neuralgia, erythromyalgia of the head, erythroposalgia of Bing, hemicrania angiopolytica, hemicrania neuralgiformis chronica, histamine cephalgia, Horton's headache, Harris-Horton's disease, migrainous neuralgia of Harris, petrosal neuralgia of Gardner, Sluder's neuralgia, sphenopalatine neuralgia, Vidian neuralgia. So what are these? These are attacks of severe, strictly unilateral pain, which is orbital, supraorbital, temporal, or any combination of these sites, lasting 15 to 180 minutes and occurring from once every other day to 8 times a day. The pain is associated with ipsilateral, it means one-sided, conjunctival injection, lacrimation, nasal congestion, rhinorrhea, forehead and facial sweating, miosis, ptosis, and/or eyelid edema, and/or restlessness or agitation. The diagnostic criteria for cluster headache are A, at least 5 attacks fulfilling criteria B through D. B is severe or very severe unilateral, orbital, supraorbital, and/or temporal pain lasting 15 to 180 minutes when untreated. C is either both of the following. At least one of the following symptoms or signs present on the same side as a headache: conjunctival injection and/or lacrimation, that means the eye turns red; nasal congestion and/or rhinorrhea, that means clear fluid for the nose; eyelid edema, that means swelling of the eyelid; forehead and facial sweating; miosis, which means the pupil on the involved side gets small; and ptosis, which means the eyelid on the same side droops. And 2, a sense of restlessness or agitation. D is occurring with a frequency between 1 every other day and 8 per day. All right. So these cluster headaches come in attacks in series lasting for weeks or months. That's the so-called cluster period or the cluster bout, separated by remission periods, usually lasting months or years. About 10 to 15% of patients have what's called chronic cluster headache without remissions. In a large series with good follow-up, 1/4 of patients may had only one single cluster period. Such patients meet the criteria which should be coded as cluster headache. During the cluster period, attacks occur regularly, may be provoked by alcohol, so the patients don't drink then, histamine, or nitroglycerin. Nitroglycerin is a vasodilator. It might be given to patients with coronary artery disease, such as angina, where it dilates the coronary artery, but it dilates the brain artery, gives you a headache. The pain of cluster headache is maximal orbitally, supraorbitally, temporarily, any combination of these spikes. It may spread to other regions. During the worst attacks, intensive pain is excruciating. The patients are unable to lie down and characteristically pace the floor. The pain usually recurs on the same side of the head during a single cluster period. The age of onset is usually 20 to 40 years old. And for unknown reasons, men are affected about 3 times more often than women. Acute attacks involve activation in the region of the brain in the posterior hypothalamic gray matter. Cluster headache may be an autosomal dominant condition in 5% of cases. Some patients have been described as having both cluster headache and trigeminal neuralgia, which is called sometimes the cluster tic syndrome. And the patient should receive both diagnoses. All right, so that's cluster headache as a definition. I'm going to go in and discuss the pain description in some more detail. All that I read you before is from the International Classification of Headache. The pain begins quickly without warning. So migraine onset peaks at like an hour, 30 minutes or something like that. Tension-type headaches come on very slowly, like hours. But cluster headache comes on in minutes. The pain is excruciating in intensity and explosive in quality. Rarely the pain is pulsatile. Migraine is usually pulsatile. Patients describe the headache as a killer headache or suicide headache. The patient may be boring, stabbing, burning, like a knife, like a hot poker in the eye. And sometimes it's described as pulsating, throbbing, squeezing, or aching. At the end of the attack, the symptoms resolve in 1 to 2 minutes. Let's go over the location. The pain of cluster headache is located in one temple and behind or above one eye, period. Sometimes the face, neck, ear, or one side of the head be involved, but that's unusual. Cluster headache pain is persistently one-sided in location. Migraine without aura headaches are unilateral in 60 to 70% of the time, but cluster headaches are always one-sided. Migraine may switch sides back and forth, the patient usually stating that one side is more prominent. Like, my migraine used to occur on the right side most of the time, but occasionally they occur on the left. But cluster headaches are always one-sided, and switches to the other side and occurs in 50% of patients, 15% of patients, usually for the duration of one bout. Rarely the pain will switch sides during the cluster headache period. That's very rare. The associated symptoms, I've already mentioned to some degree. I'm going to go over them again here. The patient may have characteristic autonomic symptoms. Lacrimation from the eye affected with pain is the most common associated symptom. That means tearing from the eye. The autonomic nervous system is a wired nervous system connecting the brain through the spinal cord and ganglia to a target organ. For instance, with tearing, the autonomic nervous system connects to the lacrimal gland to produce tears in the eye. The autonomic nervous fibers enter the eye wrapped around the carotid artery and go to a specific anatomical areas. These autonomic fibers innervate the pupil, causing dilatation or constriction, and the nasal terminates to produce mucus. And a small muscle in the upper eyelid helps hold the eyelid up. Autonomic fibers also innervate the sweat glands over the forehead and the blood vessels, which course over the surface of the conjunctiva, the white part of the eye, and that's why it gets red during the attack. All of these so-called autonomic symptoms of cluster headache affect altered, usually temporarily, dysfunction of the different fibers. Not every cluster headache has all the symptoms on this list, but they may have 3 or 4 of the cardinal symptoms. Usually family members will comment about the upper eyelid drooping, which is called ptosis, P-T-O-S-I-S. A small pupil on one side may be noted by a family member or the patient, only if they're very observant. Usually they don't. Redness of the conjunctiva, which is the white part of the eye, may be noted by the patient. They look at themselves closely in the mirror. Tearing, called lacrimation or nasal dripping, and congestion is pretty obvious. In my experience, forehead sweating is not a prominent symptom, but may not be noted by the patient. Sometimes a patient with chronic cluster headache may develop an upper lid pupillary syndrome related to damage of the tiny autonomic fibers in the carotid artery on that side, called Horner's syndrome. Patients with Horner's syndrome present with mild upper lid drooping so that the lid may fall down below the colored part of the eye. This is usually not bad enough to obscure vision and may be just a few millimeters of change. Although Horner's syndrome is associated with smallness of the pupil on one side, a condition called meiosis, these may also be lacking in sweating or anhidrosis over the forehead. And so many medical students memorize the classical findings of Horner's syndromes, which are ptosis, lid drooping, meiosis, small pupil, and anhidrosis, which means dryness, a wetting of the forehead with sweating. Nausea, vomiting, sensitivity to light and sound may occur with cluster headache with these symptoms not as prominent as they are with migraine without aura. Okay, onset and duration. Cluster headaches come without warning and reach a peak within 2 to 15 minutes. This is different from a typical migraine without aura, which may take half an hour or several hours between the onset and the peak of the headache pain. Cluster headaches are very severe, quick onset, one-sided headaches, which consist of pain around the eye, temple, or cheek. Cluster headaches may track the clock, coming at the same time every day. This periodicity is a key feature of cluster headache. The attacks of pain occur at the same hour every day for the duration of the cluster bout. The attacks characteristically occur 1 or 2 hours after going to sleep in half of patients. An attack at this time occurs and responds with dreaming and REM stage sleep. Some people have several attacks at night, consistently interrupting sleep. Some patients get daytime attacks associated with napping or relaxation. 75% of attacks occur between 9 p.m. and 10 a.m. The duration of the attacks ranges from 15 to 180 minutes, with most cases lasting almost 30 minutes to 2 hours, with a mean time of 45 minutes. The attacks may occur 1 to 8 times a day, and the patient is pain-free between attacks. The cluster period. The headaches come in time periods called clusters, like grapes grow on a cluster on a tree, which usually lasts 6 to 12 weeks. The term cluster here means that the headaches cluster together in time. Thus, the patient may state he had 6 weeks of headache in March and April of the year 2004, but then the headaches completely stopped. Following this, there were no headaches at all in 2005, but they started again in March of 2006, and this time brought the patient to the doctor. Although the usual cluster period is 1.5 to 3 months, we've talked about before, some patients will have 10 to 15% will have chronic cluster headaches all year round. And in this group of patients, the term cluster is meaningless, but it's still used. Also, cluster patient may cycle between intermittent, the typical cluster pattern, and chronic daily cluster headaches. Chronic cluster patient may be involved in the episodic form without treatment. Although some cluster periods occur in the spring and fall, other researchers have found cluster cycles in February and June that seem to occur at the time of increase in daylight hours. Cluster attacks occur 7 to 10 days before the longest and shortest day in the year, suggesting the pineal gland located in the center of the brain may be involved. The pineal gland responds to ambient light and helps set the sleep cycle. I want to focus next on behavior during the attacks. The patient usually gets up and paces around the room. Sometimes they may sit, but they don't lie down in bed in a quiet room with the lights out like a typical migraine patient would do. And they don't miss work like a migraine patient would because the attacks are short and they're over with, and they're then free of symptoms. Blau in 1993 wrote an article in The Lancet on, quote, the behavior during a cluster headache, and here's what he stated. The patient walks around with the trunk slightly bent forwards and clutches the head, or sits rocking backwards and forward with the hands pressed on or near the painful site, was the most common behavior during attacks. Self-trauma, a common feature, included pressing a finger, thumb, or fist into the affected eye or adjacent temple, hitting the forehead against a hard object, the wall, the floor, a radiator, or mantelpiece, or rubbing or pressing the forehead on the affected side of the carpet, chair, or bath side. Others repeatedly hit or painfully scratched the head distant from the painful site. One rubbed his thighs until they became red and sore. Clenching fists so that the fingernails dug into the palms, implying intense heat, like a boiling cup of tea or hot water bottle, or ice-cold objects to the forehead were also described. In 2 patients with lower half cluster headache, pain radiating at the upper jaw instead of upwards over the head, one inserted and twisted a steel knife blade between the painful upper tooth, while another pushed a fingernail as hard as he could into a tooth socket in the painful region. 3 pushed a cotton wool tip up the affected nostril, while another blew his nose very hard, each to provoke the rhinorrhea that heralded the end of their attacks. Associated features also is that the headaches can be aggravated by alcohol only during the cluster time. If a migraine patient reacts to a certain alcoholic drink, the migraine may come on any time the patient drinks that type of alcohol. But the cluster patients say that a beer or a glass of red wine will immediately set off a headache during only the 6 to 12 weeks when the headaches come. But alcohol has no effect on reducing headache between cluster attacks. And as I've mentioned, the vasodilator nitroglycerin is also causes, along with histamine. Distinguishing patient features. These patients often have a driven, type A workaholic nature. They tend to be ambitious, efficient, conscientious, striving, compulsive, self-controlled, self-sufficient, reserved, and tense. They also tend to smoke cigarettes and drink alcohol more than the usual person. I recall myself a patient I saw years ago who had cluster headache and had the typical driven lifestyle some of these patients have. In his small town, he was the sheriff, voluntary fireman, and emergency ambulance attendant. He did these jobs on the side while running his family business during the day. He carried 4 beepers. That was in the time before a cell phone. Some doctors in the past have described people as being macho who have cluster headache. Some people describe them having square faces or lines in the faces or being taller than the usual people. Nosology, I'm going to discuss that. The title itself, cluster headache, causes confusion in the lay and in some doctors' minds. Several times a month, I'll talk to a patient who will tell me that their doctor said he had cluster headache because the patient has several headaches in a row. Usually the patient has migraine without aura that is partially treated with acute therapy medication, and the patient's had one big long headache with peaks and valleys. Many of these patients have a diagnosis of medication-overuse headache and have central sensitization causing the headache. There was a lot of confusion in the literature when this syndrome was first recognized. At the start of my career in the late 60s, I was taught to call this headache vasodilating headache, which I did for a few years until the cluster term rose to prominence, and then it stuck. Other names offered I've already mentioned. I think what happened was all these articles were published where people had these names, migrainous neuralgia, histamine headache, histamine cephalgia, Horton's headache, and all that. And someone sat back and said, we're all describing the same thing, let's just call it cluster headache, and that's what was done. So cluster headache is now firmly established as a distinctive syndrome. Epidemiology. Cluster headache occurs in approximately 69 cases per 100,000 people, and it's much less common than migraine. Men are affected more than women. It usually occurs between ages 20 to 50. It has a mean of 30 years. However, it may begin as early as the first decade and run as late as the eighth decade. Attacks in women with cluster headache usually did not come with their menses. They generally stop during pregnancy, but like migraine, may be started by the use of oral contraceptives. Women may have both cluster headache and migraine, but they're commonly only diagnosed with migraine. There have been some statements made that women have more cluster headache now than men do, due to the fact that more women are in the working role, and that may be something, the stress of that aggravate this syndrome. The age of onset. The typical age of onset is the third decade, which would be called 20 to 30 years old, but the range extends from 20 to 60 years. And many persons with cluster headache have family members with migraine. I'm going to review some of the history of the different persons, famous in neurology, who described this syndrome. So the history of the various terms used to describe this painful disorder has a long serpentine story weaving back into the 18th century. Most authors give early credit to the description made by von Mollendorf, who in 1867 described red migraine with hemicrania, homolateral redness of the face, injection of the eye, lacrimation, and dilatation of the temporal arteries. However, an earlier report was made by Gerhard von Sweden, who gave a full description of cluster headache, meeting IHS criteria in 1745 in his textbook of clinical medicine. Von Sweden was the founder of the then leading medical center at the Vienna School. His article, lost because it's really written in Latin, was only found again in 1992. Wilfred Harris, in 1926, described a special recurrent headache which he called periodic migrainous neuralgia. In 1936, the British Medical Journal, Harris wrote about the subject, again using the title of ciliary or migrainous neuralgia. Harris was the first to describe successful treatment of the attack of cluster headache with ergotamine. In his 1936 article, Harris offered his definition of migrainous neuralgia. Quote, I've employed the term migrainous neuralgia to describe cases of recurrent neuralgia affecting the temple or the side of the forehead and often both jaws, sometimes extending the back of the head, usually strictly one-sided. The pain in these cases is often most intense and excruciating and may start suddenly or gradually and subside in the same way, the duration of pain varying from 10 minutes to half an hour or from 5 or 6 hours, and occasionally for 24 hours for periods of 6 to 8 weeks yearly. Nausea occasionally comes in pain, suggesting its association with migraine, but vomiting is rare, and visual spectra and transient hemanopia are never met with as in the usual form of migraine. I'll quote from a case of Harris had he described in his article. In one case, indeed, a man of 40 suffered almost continually for 3 weeks, having had only 8 hours sleep during that time. His first attack began when he was age 37, and the longest interval between attacks was 2 months, the severe pain lasting usually 1 or 2 weeks, being continuous and limited strictly to the left eyeball. Harris stated, the patient is described by various sufferers as, quote unquote, intensely severe, very excruciating. The eye feels as though being hammered or rolled on the ground. The eye feels as if being pulled apart or turned out like boiling water over the eye. Dr. Horton of the Mayo Clinic, famous neurologist, spoke about a new syndrome which he had originally named erythromyalgia of the head in 1939, but changed it later to histamine cephalalgia in 1941. Horton at the Mayo Clinic called the syndrome histamine headache in 1939. One of Horton's cases came from his 1939 article follows. I'm going to quote about a case of his. Vasodilating pain in the left eye associated with left hemicrania and precipitated by drinking beer. A man aged 58 gave a history of recurring pains in the left eye of 12 months duration. The attacks occurred either during the day or night and often wakened him from a sound sleep. The onset of the pain was gradual, and he localized behind it the left eye. It was a constant, sharp character, but no throbbing sensation was present. When the pain lasted more than 1.5 hours, it extended to the left temporal and occipital regions and into the neck. It decreased in the orbital region as it increased in the neck area. This pain also persisted for 4 to 5 hours without associated nausea or vomiting. The drinking of alcoholic beverages, particularly beer, invariably precipitated an attack of pain in the left eye after an interval of 30 to 50 minutes. The pain was reproduced on 3 different occasions by having the patient drink a bottle of beer. Compression of the left carotid artery gave momentary relief. Then Gardner described in 1947 what he called greater superficial petrosal neuralgia and suggested treatment by resecting the nerve. Wow. Cluster headache was used by Kunkel in 1952 and then by Friedman and Michalopoulos in 1958. In 1956, Sir Charles Simmons, writing in the journal Brain, gave a more complete account of the syndrome of cluster headache in an article entitled, quote, A Particular Variety of Headache, end quote, which helped to educate the general medical audience, the public, about this little-known malady. Simmons stated about the syndrome, its essential features are the occurrence of paroxysms of headache, that is to say pain of sudden onset and transitory duration, which occurs in bouts lasting for several weeks and long intervals of perfect freedom. In the paroxysm, the pain is felt mostly in the supraorbital region, on or in behind the eye, although it may spread beyond this region. It is, however, strictly unilateral. It is agonizing severity, but very rarely lasts longer than 2 hours and often less. During an episode, there's usually one paroxysm in each 24 hours. There may be more. In the intervals between paroxysm, there's complete relief. The bout having ended, there's no further complaint of headache until the occurrence of the next hour after an interval of freedom, which is rarely less than 6 months and maybe several years. No local cause for pain is found. And so I'll give you now a report of one of Simmons' cases. He saw a male aged 39 when first seen in 1948, who said that at the age of 35 he began to have attacks of pain behind the left eye, described as like pain in a tooth exposed to the cold, reaching peak intensity in 15 minutes, remaining thus for an hour and a half, and rapidly disappearing, but sometimes followed by a dull ache for an hour or two. At the height of the attacks, the eye would water and become bloodshot, and the left side of the nose would feel blocked. The attack would usually begin between 2 a.m. and 3 a.m. and would be repeated for 2 or 3 nights in succession. And after an interval of 6 to 8 weeks, the experience would be repeated. When seen again in November 1955, he reported the nature of the attacks had remained unaltered, but that the series of bouts had gradually become longer, lasting up to a fortnight, which was like 2 weeks, and intervals between bouts also lengthened to 6 months. Then, in the summer of 1952, he had a bout lasting 4 weeks, followed by complete freedom for 18 months. There was then a bout lasting 2 weeks, again followed by freedom for 18 months, when he began a bout which had lasted 5 weeks when he was seen. In this, the paroxysms had occurred at irregular times, mainly during the night, but occasionally during the day. On 2 occasions, there had been 3 paroxysms in 24 hours, but on several occasions, he'd gone 24 hours without an attack. Now, sort of a summary statement here. Cluster headache is now considered to be one of the trigeminal autonomic cephalgias, a group of primary headaches which include paroxysmal hemicrania, short-lasting unilateral neuralgiform headaches with conjunctival injection and tearing. That's called the Sunk syndrome, SUNCT. And the area of the brain that's involved is thought to be in the posterior hypothalamic gray matter. So this concludes my discussion of the terrible symptom and headache of cluster headache. I hope none of you people listen to this have it, but if you do, God bless you and hope you get better. Please check the registered note on this podcast so you can hear me later. And good luck to all of you. God bless.